Okay, well, it's 10 o'clock, and to be respectful of all of your time and our guest's time, who is coming to us all the way from Wisconsin. So we're very excited. First of all, I'm very excited to have our education hour, which we haven't had for a few months, but we're so excited to get them up and running again. And with a great bang to a start on this particular education hour with Erica joining us today. I happen to know Erica personally as we both travel and teach for LSVT Global. I'm going to let her tell you a little bit about that. We both travel and teach the treatment approach LSVT Big. So I know she is an amazing clinician. I've seen her in action. She is kind of unique in that she also has this specialty in bowel and bladder, or pelvic floor, as we call it in the therapy world, related specifically to Parkinson's. And I cannot tell you what an amazing treat this is to have her as a speaker, because she actually is the creator of the program for clinicians being trained in pelvic floor rehab specific to Parkinson's and the challenges that occur with that. So I am not going to give the full welcome and introduction to Erica, because she is so much better at knowing her history. But I just wanted to share with you that I can vouch for her as an excellent clinician and an amazing speaker. So Erica, we want to thank you, and I'm going to open it up to you to introduce yourself.
Hi, Trisha. Thank you so much. This is very exciting to be with you guys today. It looks like we have a really nice group. My name's Erica, again, like Trisha said, and I'm actually an occupational therapist. So I have been extensively trained in bladder and bowel health related to just the general population, male, female, and I also work with kids. But really, my passion is Parkinson's disease and helping people that are dealing with both the disease and these non-motor symptoms, we might call them, as bowel and bladder issues can come up really commonly in Parkinson's disease. So I'm really excited to share that with you today. So I've been an occupational therapist for about 22 years now, and I grew up in Wisconsin. I'm based in Wisconsin. I work full-time for a large hospital system, Aurora Healthcare. And we recently joined with Advocate Health, which is more in the southern United States. The Advocate Health and Atrium Health, we're just growing immensely. When I first started there, it was like 30,000 employees, and now we're like 150,000. So we've just become a huge health system. But I work in downtown Milwaukee. And I have a clinic in the outpatient area of the hospital there, where I work with people with Parkinson's disease for LSVT Big, as Trisha said. And I also do the pelvic health treatments. So that is what I do all day long, besides teaching Trisha on the weekends on occasion, when we have the opportunity to teach together and share with clinicians all this great information. So I authored a course, as Trisha mentioned, called Parkinson's Disease and Pelvic Rehabilitation, for one of the really nationwide training program kind of company for pelvic health clinicians. So OTs and PTs can take my course if they have a special interest in helping people with Parkinson's. And I have a 2-day course where I help them to just dive deeper into specifically how bowel and bladder issues affect people with Parkinson's. So I am board certified in 2 different areas of pelvic health, both for biofeedback for pelvic muscle dysfunction, which I'll talk a little bit about today, and also am board certified in pelvic rehabilitation. So besides my OT degree, it's something that I've pursued beyond that to get my education. So I can't wait to share more with you today about specifics. So let me share my screen with you here. And I think we're all set, Trisha. If you can't
Nope,
see it, just let
you
me
were
know.
seeing black. There we go.
We got it?
We're
Okay.
good. Now,
Sure.
did you want, I just wanted to interrupt for a second. I didn't remember to share that we're going to have you do your little share with us, your presentation, and then maybe we can ask class questions at the end. Is that how you'd prefer to do it?
That would be fine. Yeah,
Okay, perfect.
absolutely.
All right. Thank you.
Yeah, very good. And do you see my video box, Trisha, or do you just see my PowerPoint? Oh, just the PowerPoint? Okay.
Yeah, the PowerPoint, and then Yeah.
Okay, perfect. Excellent. All right, so let's specifically talk about Parkinson's and bladder and bowel challenges. And I'm just going to start off with talking about the pelvic floor, which is really the muscle that we speak to in regards to the main control of our bowel and bladder. So when we think about the pelvic floor, really, what is it? So it's a sling of muscles that supports all the pelvic organs, really from the front to the back. So it attaches to the front of our pelvis at what we call our pubic bone, and then goes all the way back to our tailbone and attaches to all the sides. And it's kind of like a sling of muscle or a bowl of muscle at the base of our pelvic area. And we like to call it the 5 S's of pelvic function, or all these different things that it does. And this is an easy way to remember it. So the first of the 5 S's is sphincteric, that this muscle really helps to allow for closure, to control urination, for bowel movements, for gas release, things like that. And the sphincter is around all of those openings that exit the pelvic area. So we need that sphincter to be able to close or to open as we need it to throughout the day for whenever we need to go to the bathroom versus control things. And then it also provides support. So it's that shelf holding everything in: our bladder, the uterus in females, the prostate in men, and the rectum colon. So it's holding everything up and keeping everything inside. Additionally, it has a sexual function. So both for male and female, it provides engorgement or orgasm control in both of the male and the female. Now, it also works with our core muscles. So when we think about our abdominals, we think about our core and getting stronger. And it also just helps to stabilize that whole center of our body and provides that core stability for balance and just for stability of all of the organs, like I mentioned, for support and things like that as well. And then it also has a sump pump function, and that's really to just keep all the fluids moving through so we don't get swelling in our lower body. It kind of just pumps everything back up to our heart, along with our other muscles of our legs and abdomen. So this is just a little side view of what the pelvic floor muscles look like. So we have on the left-hand side is the male pelvic floor, and on the right-hand side is the female pelvic floor. So when you look at the pelvic floor muscle, it's the red little sling right here. And in the male, the prostate is above the pelvic floor muscle, and the bladder is above the prostate. And then you have the anorectum right here in the back. And then the longer urethra in the male. And that's that tube that exits the bladder for urinary release. Additionally, in the female, then we have the red floor muscle. And we have the bladder here in the front with a shorter urethra in the female for urine to exit the body. And then we have the uterus in the center, which sits just above the bladder. And then there's the vaginal opening through the pelvic floor muscle there. And then the anorectum in the back. So just to kind of show the differences of where that muscle is in both the male and the female is kind of a nice depiction there. And how I mentioned, it's kind of like bowl-shaped or going from the front to the back. You can think of it even like a hammock here, that the pubic bone is in the front, the tailbone is in the back, and the bladder, rectum, uterus, and prostate sit in the center, and everything gets held up by that muscle. And so when we want to think about the bladder has certain things that it should typically do. And the normal bladder function is that the bladder can really hold up to about 2 cups or 16 ounces of urine. So that's about 400 to 600 cc's. And the average person urinates about 5 to 8 times a day or once every 2 to 5 hours. And that is very dependent on what you take in, of course. And sometimes certain things make you go more, like caffeine, and we'll talk a little about that as well. The first sensation of needing to go to the bathroom should happen when the bladder is about half full, so about that 6 to 8 ounces. And that doesn't mean necessarily that you'd have to go when it's that full, but that would be that indication like, yeah, there's something in there, I might need to consider that in a short time from now. And the bladder is supposed to empty completely each time you go to the bathroom, and there should be no leaking of urine. That is not a normal function, and we talk about how we can help with that if that is a problem. And you really should only have to get up about 1 time a night, maybe 2 as we get a little bit older, but 0 to 1 times a night is more within that normal function. So the way that you can tell if you're hydrated, I get a lot of questions about, how much water really should I drink? And that recommendation can vary depending on your health status, if you have heart disease or kidney problems or things like that. But in general, a way to best tell if you're hydrated is by looking at your urine color. And so that 3 to 4, kind of that light lemonade color, is a great place to be, knowing that you have enough fluid in you and that you are more hydrated. On average, they say like half your body weight in ounces, but for some people, that's kind of a lot of water. And in some people, that might not be enough water. So it almost is better to either think about it in a color, analyzing your urine color, or even just trying to shoot for around those 8 cups a day, which has been kind of a standard recommendation for a number of years. So the normal bladder, what it has to do in order to maintain what we say is continence, meaning control, no leakage, is that during storage, the bladder remains in a very relaxed position. The bladder is a muscle, and as it fills up with urine, it's supposed to stay really relaxed. And our sphincter or pelvic floor muscles are kind of contracting or tightening just to support that. And we might not even have to think about that. It's just happening automatically. And it's just keeping everything in storage mode while we go about our day. And then there's this transition stage where we start to recognize that there's some fullness there. We can kind of ignore the urge to go if we need to, if we're not in a socially appropriate place. And we can inhibit or calm our bladder down by contracting our sphincter or pelvic floor. And then the last kind of event that can happen with the bladder is the emptying. And during emptying, we're supposed to be able to just sit down on the toilet or stand. If you're a male, if that's the way you urinate, and your bladder does all the work, you just relax. The bladder is supposed to do the squeezing. You're not supposed to have to strain. And the pelvic floor and your sphincter just relax and let the urine go out. And then it starts all over again. And so when we think about when the bladder isn't doing what it's supposed to do, there are 3 types of incontinence we can kind of think about here. So the middle one is when there's pressure, like with a cough or a sneeze or a laugh, and pressure goes down on the bladder and you get leakage because of that pressure from a cough, sneeze, or laugh, or maybe lifting something. The one on the left is the bladder is very full, but maybe you don't feel that it's full and it leaks, and it's called overflow incontinence. So it kind of just sneaks out because your bladder is so full and you actually don't really feel it that it's full. So that's an important thing that we look at in therapy to determine if you actually are emptying your bladder completely or if your bladder is really filling up and you can't empty it completely. So something very important to look at. And then the one on the right, which is one of the most common incontinence types in people with Parkinson's, is urge incontinence. So kind of what you see around the bladder, those exclamation kind of like, woo, it's very active. So what happens is when the bladder fills even a small amount, people with Parkinson's tend to have urgency and frequency where they go a lot and the volume is actually pretty small. So we can get leakage with that as well, meaning the term urge incontinence, meaning you get an urge and you can't hold it back and a little bit of urine leaks out. So we have urge incontinence, which is that, and then the middle one, stress incontinence. We put some stress on the bladder and it leaks. And then the one again on the left is overflow incontinence. The bladder's too full and it leaks out. So very important to kind of figure out what type you have so we can work on that. Now, I wanted to mention 2 things about kind of the body in a female and the body in a male and how things differ a little bit. So in a female, what can happen as we age, in addition to things that happen with Parkinson's, is that there can be something called prolapse. And that's when things kind of sneak down through the vaginal canal. So over here on the left is what it should look like normally. You have your bladder and your uterus above with that nice long vaginal canal, and then the anal rectum in the back. And over here, it's showing how the uterus kind of is sneaking down into the vaginal opening, and it actually causes a little bit of a kink in the bladder right here. And so that can be a big challenge for emptying the bladder. You can get a little pocketing of urine. Maybe you get bladder infection, something like that. But that can also happen with the rectum too, where a little bit of stool gets kind of caught in this little pocket here. So you may have heard the terms from your doctor if potentially you have that, like a uterine prolapse or what they call a cystocele, and that's the bladder falling down, or a rectocele, that's the rectum falling down. And these are more common in females. Now, in males, we have to deal with the prostate. So the normal prostate should be kind of relaxed and real smooth and leave the urethra, that tube that exits the bladder, nice and clear and free flowing. But as men get older, they get a prostate that might look something like this. This may be more exaggerated, but it may get more lumpy or might potentially develop cancer, or may just be benign, and it's just compressing the tube, and the tube gets more narrow, and now the urine can't get out of there very easily. And actually this situation also makes the bladder very aggravated. The bladder's job is to protect the kidneys by letting out urine, and therefore this puts a little compression, and now the bladder's going crazy over that. So in men, we kind of have a double whammy. We have enlargement of the prostate that can cause overactive bladder, but we also can get the Parkinson's that also can cause overactive bladder. So the reason that in Parkinson's, the bladder can become overactive is because the area where the dopamine is in the brain is also supposed to control the bladder's calmness during filling. So when the bladder is filling up, the area where the dopamine is produced in the brain is supposed to be telling the bladder, just relax, we have things to do. We can just fill it up and store it really nice and quietly. But in Parkinson's, that doesn't so much happen. So what we really want to figure out, and in therapy, what I do with a lot of my patients is I have them do like a measured bladder diary where I have them actually I want to see, what are these volumes? What are the volumes that are coming out? Are they a lot? Are they a little? If measuring isn't possible for someone, I obviously give them something to do that with, but also counting is a fine way to do it as well. It's not perfect because everyone's stream is a different speed, but if you counted 1, 1,000, 2, 1,000, 3, 1,000 while you're urinating, most people with Parkinson's only count very small amount, like maybe 3 1,000s, 4 1,000s, and we really want to get to somewhere between 8 and 12 1,000s when you're emptying your bladder, because that would tell us that we have about as much as a normal bladder would hold. And so those small volumes are something that we can work on in getting the bladder rehabbed. We can definitely work on that in therapy. And then that would obviously help, hopefully, with the urgency and the frequency, which is also very common in Parkinson's. Because as I mentioned, the part of the brain where the dopamine is produced is supposed to be calming the bladder while it's storing urine, but it's not doing its job to do that. Leakage can be very common, and this can be due to just weakness in the pelvic muscles, or maybe some of those changes in the anatomy that I just mentioned, just with aging. And another common one in Parkinson's specifically is nocturia. That is meaning that you're getting up more than 1 or 2 times a night to go to the bathroom, and it could be very urgent, and maybe those volumes are really small. And so that can be related to maybe your off time of your medication. That can be related to just this overactive bladder that we can try to train down, and we can help work on that, which is really great. And then pelvic floor slowness. So you know how the other muscles in the body, like for walking or for the doing something with your hands, like difficulty with handwriting and all those things. And when that becomes slow, the pelvic floor also can become slow too. So the reaction time to an urge might be slower than it would have been before having Parkinson's. And so we can work on training the speed of your pelvic floor, the bigness, like in LSVT big, how we train big muscle movements. We can actually train bigger pelvic floor movements and faster pelvic floor movements to help with urge control. So there's a lot we can do about it, which is great. Okay, I'm going to transition to the bowel, and I'm happy to answer more questions after we're done as well. So we'll just transition to this, and then we'll be open to questions after we talk about a few more things. All right, so normal bowel function is that you'd have a bowel movement 3 times a week to 3 times a day. So it's kind of a big range. Most people feel best when they go about once a day. But 3 times a week is still within the average or normal bowel function. And we aren't supposed to have any leakage of bowel or fecal material at any time. The consistency should be pretty soft and formed. And ideally, there's an awareness or present of the presence of stool within the rectum. So our sensation is very important to have normal bowel function. We have to be able to feel that it's present and ready to go. Now, with constipation, the reason I brought the sensation thing up, with constipation, where you might have like this type 1 or type 2 bowel movement, this is called the Bristol stool chart. When it gets very lumpy and hard, sometimes if you have that for such a long time, the sensation of how much is in there gets kind of abnormal, where you might not actually feel like there's that much there. You might feel maybe bloated or have a little bit of abdominal discomfort, but you might not feel actually how much stool is actually in there as the bowels do that for, say, a long period of time, because your rectum gets really overstretched and we start to lose the sensation of what might be there. And really, so then that being said, our goal is trying to get to type 4 on the Bristol stool chart, that we want to have more sausage-like or snake-like smooth bowel movements that are pretty easy to pass. We want to stay away from the liquidy stool or the very hard stool. And normal events of how the bowels should be controlled are really starting off with when we eat. So it's called the gastrocolic reflex, and that is related to the stomach and the colon. So when we get up in the morning, we take in food or we take in some coffee or a warm drink, and that kind of gets that initiation of our belly going, and that's called peristalsis. So that's that movement in our colon that gets things going so we can be ready for our bowel movement. And during that time, our sphincter and our pelvic floor muscles might be in a little bit of a contracted state so that we don't have like leakage or anything happen unexpectedly. And we might not even have to think about that. That's just kind of doing its own thing. It's automatic. And then we get this awareness, just like with the bladder. So we get this stretch in the rectum and it sends this sensation of urge, and then we become aware and we can squeeze our pelvic floor to keep it inside for us to be in a socially appropriate or a time when we can make it to the bathroom in time, and we can just briefly delay that. And then during evacuation or bowel movement, our rectum is supposed to do most of the work. We're supposed to get a squeeze of the rectum, just like we do with urination in the bladder, squeeze of the rectum, and then our pelvic floor and sphincter should be totally relaxed during that. And then completion, the rectum now relaxes and gets ready for more bowels to kind of move into that area. And our sphincter and our pelvic floor kind of goes into that contraction state again so that we don't have leaking. And so with Parkinson's disease and the bowel, there's a lot going on that could be happening. So our colon, this is a little depiction of the colon or the large intestine, same terminology, in that there is slow motion through the colon for people with Parkinson's. So things can move a lot slower and kind of get more hard because more water gets sucked out of the bowels the longer it sits in there. So the colon just moves a little slower. It does rely on dopamine in order to move things along. And so that can be a big problem. And we know that our carbidopa levodopa does get absorbed after it goes through the stomach. So it gets absorbed in the small intestine, which actually is in the center of our large intestine, kind of around our belly button. And so when things are moving really slow, our carbidopa levodopa might not be getting to the small intestine quick enough because everything is a little slower. And so it can affect the effectiveness or the quality of the medication when you need it. So it is important that we work on these bowels, get them moving so that your medication can work really well. And then a weak rectum. So what happens with Parkinson's is that sometimes the rectum actually loses some strength and doesn't contract like it should to empty out. And so we have to kind of train the abdominals or maybe some breathing techniques to help get the rectum to contract a little stronger. Straining with breath holding is actually counterproductive. It usually closes the sphincter or the pelvic floor. And so I do a lot of work with breathing and kind of training how to get the bowels to move with using the abdominals. But as we know, and we've talked about, is that sometimes the other muscles in the body aren't working as efficiently as they should be either. And so sometimes it takes a little work to get those abdominals to do that work for you. But we do have some techniques we can try. And then lastly is the exit, so the emptying. there sometimes is a difficulty opening the sphincter or the pelvic floor while you're trying to get the rectum to push out the bowels. And what happens is they don't coordinate together. So we might get closing of one while the other one is trying to push it out, or vice versa. Things might just be not working in coordination. And so there are definitely ways we can work on that in therapy as well. And so just some general, I'm going to go over just some general tips, and then I'm happy to take more specific questions. But this is a really nice just summary of some very basic things you can start off with for your bladder. So the first thing is drinking enough water. Definitely that might vary a little bit for each person, but drink enough water and limit fluids after dinner time, usually at least 3 hours before bed, to try to avoid the getting up at night if we can. Certain things might irritate the bladder a little more, like caffeine or carbonation, or things that are very acidic. So citric acid in some drinks might aggravate the bladder. Tomatoes, orange, lemon, lime, grapefruit, those kind of things might be a little more aggravating, but it's not the same for everyone. So it's kind of a trial and error, seeing what aggravates your bladder versus the other person's bladder. We want to try to avoid regular, just in case bathroom trips. Now, obviously, like before we go to bed, using the bathroom is pretty normal. Before you leave for the grocery store, those kind of things. But what you don't want to do is every time you see a bathroom to just go just in case, because what happens is you kind of start to reinforce that small amount in your bladder to come out each time it only fills up a little bit. And then your bladder likes to go to that habit, and then you'll get that signal a lot sooner. So having a just in case bathroom trip once in a while when, it's convenient for like leaving the house and things is fine, but doing that all the time is not a good idea. And then taking your time when you're on the toilet. So relaxing and letting your muscles relax is very helpful so your bladder can do its job to empty. A daily bowel movement definitely also helps the bowels. They are very close in the pelvis. And when you have lots of bowel material like constipation in that space, the bladder doesn't have as much space to fill up. So bowel movements are super important for bladder control. When you have an urge, it's best if you don't rush to the bathroom. It's better to try to use your pelvic floor muscle, which I'm going to teach you about in just a second, to try to defer the urge before you start to rush or walk to the bathroom. Because if you walk when the urge is strong, usually leakage will happen. So we want to get the urge under control and kind of calmed, and then walk to the bathroom. And then squeeze before you sneeze is kind of the general advice, I would say, when we think about that stress incontinence. So that pressure on the bladder, squeeze before you sneeze, or squeeze before you cough, or squeeze before you lift, those kind of things can be super helpful. And then some lifestyle tips for the bowel is, again, drink water. That's on the top of the list for both. Super important for both the bladder and the bowel. And eating around 25 to 35 grams of fiber per day, which can sometimes be pretty hard to do, but getting it in your diet with fruits and vegetables and things like that can be super helpful. Or some people will use like a fiber supplement. If you increase your fiber intake, you definitely want to have the water, because fiber only works the best with water. Fiber takes on the water, helps to get into the stool and make it a little bit more mobile for you. But if you only eat the fiber and no water, that could actually stop you up a little bit. Having a warm drink in the morning of whatever you enjoy can help getting that motility going in your belly. Sitting on the toilet in a routine time, the bowels love routine, and so the best is about 15 to 20 minutes after a meal. Most people try to go in the morning, or like to go in the morning, or had that routine maybe when you were working, or maybe some of you guys are still working, and it's nice to like get that out of the way in the morning. Doesn't always work that way, but it's good to try to get a routine. Not spending too much time on the toilet, 10 minutes or so is probably enough. You don't want to sit there and strain and hold your breath. You want to try to actually more relax, and then maybe do some breathing techniques, relaxing, slow, full breaths into the belly to try to help the bowels get going. Using a squatty potty, that's what the stool is. They have all kinds of, the Squatty Potty is the brand name, but they have all kinds of different stools you could use to put under your feet. And what it does is it helps you to get into more of a squat position, and that opens your pelvic floor because your sitting bones kind of separate and everything can get relaxed in your pelvic floor. And additionally, having your legs up a little bit higher puts a little compression on the abdomen, which can help move the bowels along. And then again, like I mentioned before, you don't want to push or strain because that closes the sphincter. So straining in the correct way using breath is much better than breath holding straining. And try not to avoid the urge to go. I know that we typically don't like to maybe go in a public situation. However, if you ignore the urge to go, sometimes you can't get that urge to come back. So the bowels really do require us to answer that urge when it comes. So this is just a little demonstration of the pelvic floor muscle. Some of you may have heard of a Kegel or a Kegel. It's pronounced in different ways. But the pelvic floor muscle, because it's attached in the front and the back, just showing that sling, that we can actually close and lift in. It's showing a fast squeeze here of closing that muscle. So when we think about how to close that muscle, if you were, say, in a quiet room and you didn't want to pass gas in front of someone, you can feel that you can gently and privately squeeze like in the back area. You can like close and tighten that area in gently, and then you have the voluntary ability to let that go. Now that squeeze should be very private, not being seen by anyone. Your hip muscles, your abdominal muscles, your butt muscles, you shouldn't have to use any of those to get that muscle to work. It's very deep on the inside and a private type squeeze. That is the best type squeeze to help with strengthening of your pelvic floor. And so the first squeeze that I will talk about here, I just used a little circle to show, is more of a slow squeeze. So where you think about close and lift in, kind of like building on the squeeze. So it's like close and in and relaxing. And sometimes I'll have people hold that for about 5 seconds, maybe 10, sometimes even more. If I'm working with maybe even a gentleman that has had their prostate removed due to prostate cancer, we may even have to hold longer than 10 seconds sometimes. So, and even for females, sometimes we build on that as well. But that is a long squeeze, or kind of working on endurance. And then we can squeeze the muscle quicker. So where you close and open, close and open, close and open. And that one really helps with coughing, sneezing, laughing, kind of leakage that someone might have where we need to activate that muscle really, really quickly. And also, both of these can be helpful for controlling an urge. And so I'm going to just turn off the flashing of the squeezes there. But when you get an urge, you really want to be able to either tighten the muscle multiple times in a row quickly, or slowly build and hold while you let the urge pass. For some people, the quick squeezes work better, and for some people, that slow, long hold works to calm the urgency. So just some ideas there, and then using those exercises to get stronger. Now, we sometimes need our pelvic floor to squeeze when we move. So for example, one of the big complaints that I hear often is first thing in the morning, the urge is very strong, or even getting up out of bed at night, the urge can be super strong. And we need to remind our pelvic floor that really it should tighten as we're trying to get up. Because a lot of times we hold our breath as we're trying to move from sitting to standing, or we might be in a rush and we're just going for it and our stomach pushes down on our bladder and now our bladder is leaking. And so I want to encourage you to think about trying to squeeze that muscle as you stand, and you exhale your breath as you stand. Because if you hold your breath, it pushes down. So think about squeeze and exhale as you stand to try to keep the bladder under control as you get up. And sometimes even in sitting, you might want to get the bladder under control first before you stand, but this can then also help to transition you to standing without leaking, and then you can get to the bathroom in time. This can also be a great exercise to just practice your pelvic floor when you don't have an urge. So practicing on getting stronger in activating that muscle with some sit to stand exercises. And we do a lot of sit to stands in LSVT Big, if any of you guys have done that before. And that can be a nice thing to add. You can add it right into your LSVT practice. And then another thing that I do teach often is either flexibility exercises or stretching exercises for the bowels, like the abdomen, different types of twisting, rotations, or stretches, or using a massage technique. And so what we can see on this picture here is the right side of the body is the start of that large intestine. And I usually encourage people to start with some circles, kind of putting a little pressure on that right lower abdomen, and you work up the what's called the ascending colon to the upper right abdomen. And then we get a little twist in the colon and we do some circles all along the top under the rib cage. Then we get another little twist and then we go to the descending colon on your left side. So we always like to kind of start that motion right to left and go around, and then you can see down here sigmoid and rectum, and then the exit. And so if we're going to work the abdominal massage right, up, under the rib cage, down on the left and out, utilizing that maybe even before getting out of bed, if your bladder is in the ready for that, doing that before even getting out of bed to kind of just like wake the belly up, get that colon going, and then that can give us a little burst, and then maybe you eat something and now everything's kind of ready to have a bowel movement in the morning. Okay. So, Trisha, I am going to stop my share and I'm happy to take specific questions or whatever anyone else would like to know more about. I hope that was a helpful start for our discussion.
Erica, that was amazing. Thank you so much. That was a really nice, I love how you did the balance of the anatomy and then the practical information. So, and really relating it to people with Parkinson's and the unique challenges that come with living with that, with Parkinson's disease. So thank you so much. There is one question in the chat, is how much water do you recommend? Could you remind us of that amount again?
Yeah, absolutely. So 8 glasses has been like the standard recommendation forever. And now they're kind of saying half your body weight in ounces is kind of what they're saying as a general. But now again, if you think about other medical conditions like kidney disease or heart disease, congestive heart failure, things like that, you really do have to maybe ask your physician as well if you're dealing with other processes in your body that may suggest limiting water intake. So I always like to say it is standard, but it's not always perfect. And then the other way that I usually recommend people monitor is urine color. So just looking for that light lemonade color. You don't want it to be clear and you don't want it to be dark yellow. So that's another great way to see if you yourself are in a hydrated state.
Thank you. So just everyone, if you're shy about asking it a question out loud, you can type it in the chat and I'd be happy to ask it for you. Or if you have a question, you can unmute and just ask a question. It looks like Hari has a question.
I have many questions, but I'll start with one. Many times when I go for urine discharge to the bathroom, it happens in piecemeal. Like it'll happen for a little bit. I wait, I sit there, again it'll happen, like that. It happens several times. So does it point to some special condition, or is it normal for people to have that?
Thank you for the question, Hari. I have a quick follow-up question for you. Have you ever had your prostate assessed?
Yeah, by the doctor, it's
Yes.
normal. Yeah,
It's normal.
yeah.
Okay. Okay. And you
And
said
I also went through the one you talked about, measuring the discharge during the night, especially because I wake up 5, 6 times. I had done it several years ago on the advice of the doctor, and the quantity of discharge was very small.
Mhm. Yeah.
My
And
first question is a different question. That is
okay.
even during daytime when I go to the bathroom.
Yeah. Okay. So sometimes when the bladder only has a very small amount in it, like you're saying, even when you go during the day, it sounds like it's pretty small amount of discharge or volume. Sometimes the bladder can't get a good grip. I'm going to use that just as a general idea is that when the bladder is only a little full, it just can't squeeze hard enough to get a good stream going. And so what happens is if you have a larger volume in your bladder, usually you can get a better squeeze of the bladder muscle and get a nice stream that will last a lot longer and will be stronger. So the prostate, even when you have an exam that might be normal on the outside, okay, when they use their finger to kind of palpate your prostate, sometimes the prostate could still be sneaking in the middle or on the inside, and it could be pinching off that urethra or that tube. But also, it could be that your pelvic floor muscle is not adequately relaxing. So there's a lot of factors, and in therapy, we try to figure that all out for you as well to try to figure out what would be the best plan moving forward for you. Also, physicians might sometimes prescribe something like Flomax. Have you heard of that before? Did you ever try that?
I had tried it, but it didn't make any difference.
Hmm.
It didn't,
Okay.
it didn't help me.
Okay, you were still getting kind of the spurts or
Yeah,
the just
that's
little
right.
bits of volume. Yeah, so it makes me think that maybe there is something going on with your volume in your bladder. We need to get a little more in there so that your bladder can empty a little more efficiently. How often do you go during the daytime?
It varies. Like if I have caffeine, maybe 4 or 5 times within 2 hours
Mm,
after taking caffeine.
yeah,
Otherwise, I go maybe once in 3 or 4 hours.
once every 3 to 4 hours.
Yeah, right.
Okay. Are you hydrated?
Yeah, I think so. Although I don't drink much water, but my the urine color is fine.
Okay. Yeah, I would say, with water drinking, if you could get your bladder to fill a little bit more, I would say trying to get more volume might help you. And you could give that a try, but you may need someone to take a look at if your pelvic floor muscles are actually relaxing.
Now I know what to ask the doctor for.
Perfect.
Thank you.
Yeah, excellent. You're welcome.
So Erica, I wonder, your comment leads into a question that I think would be wonderful for all of us to hear is, could you give us an overview of what a pelvic floor therapist, the first session might look like as far as evaluation, and also how people, a recommendation for how to find pelvic floor therapist in general? I can put together something for this area afterwards. I have a list going, but it would be nice to have that information. That would be great. Thank you.
Yeah, absolutely. So usually the first session, I like to have you come in and get some information about, how many times are you going each day? Some of the questions I just asked Hari, what are the volumes like in your opinion? What do you drink? What do you eat? How often are you having a bowel movement? What is your urgency like? So I like to get that subjective information first, just to kind of get an idea of what your symptoms are, and how is that affecting your life, and how does it all fit together with really all pelvic functions, not just the bladder, but the bowels, and maybe even some sexual health questions if that's a concern for you. So we try to go over that. I try to put that together with the medications you're already taking, as well as your other medical history. And then what we do is we go over the anatomy of the pelvic floor, and we may do an exam. So I am trained in internal exam. Most therapists are. If you're female, vaginal exam or anal rectal exam, and for the male, the anal rectal exam. And we're really looking at muscle. So we might palpate some of those muscles, try to figure out what your squeeze is like, what your relax is like. Is there any pain there? It should not be painful, but we want to check for pain. Physicians usually are looking at more of the organs. They're trying to find out if there's any lumps, bumps, or issues with the organs. And therapists really focus on the muscle. So we're just trying to figure out what's going on with your muscle. And then I do something called biofeedback. I commonly use this in my practice because I feel it's so beneficial for the both of us to be able to get feedback from our body about what's happening. So we use a little sensor that goes inside. It's kind of like for females, like almost like a ton into the vaginal area, or in the anal rectum for men. That's like the size of a pinky finger. And or we have external little electrodes, they're little stickers, little with gel on them that can go on the outside as well if it's uncomfortable for you to have something on the inside. And what we do is we can see it on a screen. It's like a live EMG. It's reading your muscle activity on a screen. And we can actually see, are you relaxed? Are you tight? Are you able to squeeze? Are you able to relax? And it's a really great tool for training both strengthening, relaxing, coordination, super, super helpful. And a lot of times with Parkinson's, like it's hard to tell what the muscles are doing. Sometimes we just don't have that handle on what those muscles are doing, and the visual is really invaluable. And so that is very helpful. And then other sessions might include some manual therapy techniques, either external or internal, me teaching you some strategies for at home, like the abdominal massage, how to sit on the toilet, those kind of things. Maybe even talking about water and fiber a little more, having you do a diary so that I can get a good idea of your ability. So those are some of the things you should expect from someone that is working with you in pelvic health. And then Trisha, for finding pelvic health clinicians, so the biofeedback, they just changed their name, BCIA, Biofeedback International, Biofeedback Certification International Alliance, I believe they just changed their name to. You can find pelvic health therapists there, and they have the credentials of board certified in biofeedback for pelvic muscle dysfunction. PMD, pelvic muscle dysfunction. And so individuals throughout the country that are trained in that will have those credentials. So it's BCB-PMD. They have a search, kind of find a clinician function. Herman and Wallace, they are the national rehab continuing education provider, and they have a board certification as well, and that is the PRPC, pelvic. Okay, it's PRPC, Pelvic Rehabilitation Practitioner Certification. And they have a find a clinician as well, and that's national. And then for physical therapists, so I'm an occupational therapist, I would be one that would be listed on those other two I just mentioned, but for physical therapists, you can also find them on the APTA website, which is the American Physical Therapy Association. They have a certification called the WCS, which is Women's Health certification for pelvic health. So those are the best places that I know to look for one.
Thank you, Erica. I appreciate that. That was very informative. Just so you know, there was a question in the chat from Brona regarding recording. This is being recorded and it will be posted on the website. So you can go on the website and look at it at any time if you wanted to review the material. Another question here from Rick was, do you recommend taking medication called Motegrity? I hope I'm saying that right, to help with constipation.
Good question. So Motegrity is one on the list of, they are pro-kinetic, meaning movement. So pro-movement in the bowel. And yes, I have had several people take Motegrity and do really, really well with it. It helps with that peristalsis or getting that colonic movement. There's also medications that are pro-secretory, meaning it causes secretions in the colon. And those are Linzess and Amitiza. Those would probably be the two most common ones that I see. There are others, but Linzess and Amitiza help with secretion, more fluid in the colon, and then that Motegrity helps with the mobility. They also have one called Vibrant, which is a little capsule. It's pretty new, and it actually like vibrates in the colon. So it's timed. You swallow it, and then after a certain number of hours, it vibrates and causes your colon to mobilize. So it's very, very interesting. And it goes through 2 cycles of that as it's going through different stages in your colon. So that's another one.
That's interesting.
Yeah.
Did anyone have any other questions that you wanted to unmute? We have just a few minutes left. Richard, did you have a question? I wasn't sure. You're not muted. Here, let me unmute you. Go ahead, Richard.
Okay, thank you. What about Smooth Move T?
Richard, Smooth Move T is outstanding.
Okay.
Natural, yep, natural tea. I recommend that. Actually, that's a great warm drink in the morning, or some people will do it in the evening. So it is senna based. It's natural. And senna, we know, is probably not the best thing like to take long term with pills, but as far as I'm aware, that smooth move tea is very, very good and non-habit forming that I'm aware of, and I do recommend that often.
But you say not long term or
Well, they say not to take the senna pills long term
okay.
because it can make your bowel, they sometimes say like a lazy colon or it can, cause issues. But the smooth move tea, as far as I'm aware, it's like the herbal, tea, not super strong, but enough to maybe just wake things up a bit. It seems
Yeah.
to be recommended as safe to use long term.
Okay.
Yeah.
All right. Thank you.
You're welcome.
Thank you, Richard. Anyone else have any questions?
I have a quick question. When is it possible to consult you? You are in Wisconsin. We are in Los Angeles. So is it possible to arrange it through video?
Yeah, so Trisha, I'm not, maybe you know more about this, but I believe there's still some work being done on crossing state lines with
I think
therapists.
you have to be licensed in the state of the patient.
Uh,
So that might be a problem, Hari, because I don't know that Erica is licensed as a practitioner in the state of California. So for telehealth to occur in therapy realm, we don't have reciprocity in every state. We have to be licensed in individual states. At least in physical therapy, I'm assuming it's very similar for occupational therapy.
yeah,
But it
I
is
think
for
they're
physical
trying
therapy.
to work on that because I think that's kind of been an ongoing question that has been brought up, and I have heard some work being done on that, but I don't think at this time that would be possible.
Yeah, yeah.
Ari, did you want to move to Wisconsin?
I lived there for a few years in Madison, Wisconsin,
Oh,
in
very
the
good. Right in
college.
the
Yeah,
capital. Uh-huh.
yeah, long time ago.
Okay.
By the way, my wife also has Parkinson's, and she has serious motility issues. The GI doctor had prescribed for her motility and
Okay.
also lenses
Wow. Yeah.
in the
Did either
past.
one of
Yeah.
those work for her?
No, for some other reasons it didn't, but
Okay.
her problems got solved later.
Oh, very
Yeah.
good. Okay. Excellent.
Did anyone else have a question? If you don't want to unmute, you could raise your hand and I'll unmute for you if you're not sure how to unmute. Otherwise, I don't want to keep us too long. I think we're good. So, Erica, we just want to just thank you. This was fabulous and very informative and very practical. As a clinician working with people with Parkinson's, I can tell you that I took a few nuggets that more than a few that I can actually maybe start and share. So thank you very much. And I know you guys want to give her a round of applause if you have your cameras on. We want to thank you so much. And thank you all of you who attended the PEP4U Education Hour. We look forward to seeing you at our classes and for future one. And you're getting some kudos to you in the chat box. I'm sure you can see that, Erica. Thank
Thank you,
you.
everybody.
Very good.
Thank you so much.
And so we really appreciate everyone. So thank you all for coming and look for some more announcements for future education hours. Again, this is recorded. It will be a link will be available to you archived on our PEP4U website. You will be able to find it there. And we look forward to future. So thank you all for attending.
Thank you.
Bye, everyone.
Bye, everybody.